so I can let you know what's coming up. Sorry, give me 1 second. Okay, great. Great. Okay. So welcome everybody. Today we're going to talk about cabotegravir and rilpivirine and what have we learned about failures, although with a little bit of a side note at the very beginning. And let's see what we've got coming up. So upcoming conferences. So today we'll talk about rilpivirine, some treatment failure updates. Next week we have some more cases, including another lenacapavir case. For those of you who were here last week, really interesting to think about how this therapeutic is going to fit into our armament. On the 29th of March, we will have updates from CROI. And then on the 5th of April, we're going to have an obesity management talk, which I'm very excited for. And then another new hot off the presses. So on May 3rd, Bob Silicano is going to give us a talk about HIV reservoir and cure. He and Janet just had a beautiful commentary on this daunting problem. And also, we're going to make that a hybrid in-person option, and there will be lunch served. Just sort of going off of our experience with having Monica Gandhi here last year, just nice every once in a while to have everyone have the opportunity to be in the same room if that works for you. Of course, we will have a virtual option, so people who are in the county or other programs certainly are encouraged to please attend, but also have an option to eat and see each other. So great. So I think I will start off with HIV in the news, and I'm really excited that Ethel is here because I think she can help a little bit with this latest news release. So yesterday, I believe, or maybe Wednesday, I'm not sure, the Latitude Phase 3 interim DSMB review was conducted and determined that injectable cabotegravir was superior compared to daily oral therapy in individuals with adherence challenges. I think we could all probably say knock me over with a feather on that one, but really, really critical data to help move this forward. So just some brief updates on it, and then hopefully Ethel, who I believe is our site investigator for this trial, can talk to us about it. So this is the Latitude trial, long-acting therapy to improve treatment success in daily life. There are 31 sites in the US and Puerto Rico through the ARTIS, formerly known as the AIDS Clinical Trials Group and currently known as the Advancing Clinical Therapeutics Globally for HIV, AIDS, and Other Infections, still the ACTG. They enrolled participants with challenges taking daily or ART and with viremia. So it couldn't just be like, oh, my medicine is so hard to take. It had to also be that you had detectable viremia. They were screened with genotyping for resistance to the components of the regimen, and then enrolled. And the design was that they first had incentivized support for adherence, monetary incentives and adherence support from the study staff. And then once suppressed, were randomized to either receive cabotegravir or to continue on oral ART. And then this interim DSMB suggests that all participants should be offered cabotegravir. So Ethel, I don't know what you're at liberty to discuss or not, or if you're even in a situation where you can unmute, but I think one of my initial questions, so I had one patient who enrolled in this trial and then when randomized to continue on oral ART promptly dropped out. I don't know if that was a frequent occurrence or if that was a isolated occurrence, but it's not totally shocking that, you know, people were clearly wanting to get onto injectable therapy at enrollment, and so not totally surprising. And then also, I just wonder with the DSMB what the recommendation is. So obviously, there had to be participants with viremia on their oral ART regimen to demonstrate the superiority of the cabotegravir. So is the recommendation of the DSMB that those patients be offered direct to inject without any without suppression, or that they should be re-incentivized for suppression and then get put, because the trial didn't formally test the concept of injecting without viral suppression, if I'm correct.
Yeah, thank you so much, Eileen. We were really excited to see this result and really grateful to the members of the DSMB for making this decision. So we don't have firm details on what to do with people who still have viremia, but basically you can't transition to step 2 unless you have suppressed. So the firm guidance from the DSMB was for anyone, in step 2 who's already suppressed and been randomized to oral standard of care, they should be transitioned immediately to step 3, which does have an option for direct to inject. So they, as soon as their next study visit or before, should be offered the option to transition to Cabotegravir. And a lot of our participants are ecstatic about this.
Yeah.
Because it otherwise would have been a very long wait. In terms of people in step 1, which, as you know, is now as short as 12 weeks, it's significantly shortened since the beginning of the study. We actually have 2 in step 1 right now.
Oh, wow.
And so we're trying to understand some of these parameters a little bit better around what do we do with the person who cannot suppress in step 1, who in prior iterations would not be eligible for randomization. But
so what if you're in step 2 and you have viremia? So you were randomized to oral therapy and your viral load is 3,000.
Yeah, that's our question.
Okay, got it.
The only guidance we have right now is to transition everyone who's in step 2 to step 3. So to me, that could be pretty broadly interpreted to mean anyone regardless of viral load. But yeah, I'm just looking through the talking.
Right. No, and you may not know these details. I was just curious because if that is the recommendation, then this trial could actually provide even more data about use of these injectable agents in people with viremia, right? Because presumably some of those step 2 people would be transitioned while viremic, and it would provide even more data to support the use in this population.
Yeah, I would very much hope that they're going to try to support doing that, given that there's now significant amount of pilot data and programmatic data on that. So I think that would be great and would be most welcome. And just to also note that this DSMB decision was made on the basis of 70% of the analysis population, but was compelling enough of a result to transition everyone in step 2 to step 3.
So that's amazing. And what was the target enrollment?
I think it's like 480.
Sorry, I didn't mean to ask something so specific, but I will just take that moment while you look to highlight that Ethel and Pat Fisher have done a really incredible job of recruiting and reaching out to patients. And I think our site enrolled like 13 people. Is that right?
We have 15. So
amazing.
Our promised target, and we're very excited about it. And it is absolutely all thanks to the efforts of Pat Fisher. She's been phenomenal. So it's been great. But yeah, so a population of 293 equaled 70%. So I feel like I'm doing my 6th graders math homework right now. But so whatever 293 is 70% of is the target enrollment.
It sounds like in the range of a couple hundred. So that's great. So like not 50 people, in the hundreds. And so this is incredibly helpful data. And even if we only had to do a 12-week, like even if we didn't get that additional viremic direct inject randomized controlled trial data, if we get the 12 weeks, as short as 12 weeks of suppression kind of, or oral ART kind of, that's like a much more tenable goal to talk with a patient about. So this is amazing, an amazing advance. And when I say knock me over with a feather about, I mean, clearly having to do something like get injections is easier than taking something every day for many people, but still in the absence of this data, it would be impossible to move this forward.
Yeah, but your point about your participant who dropped out, he was in the vast minority. So you have to show up to get the injections, and people were pretty incredible about showing up. Again, thanks to Pat's outreach and the work of the Bartlett Clinic in collaborating with us to engage people. So he's the only person we lost, and I think was in the grip of some significant mental health struggles and just fell off. But for the most part, people showed up. Yuka's asking about the steps. So the oral step, Yuka, for the initial period. So taking non-adherent individuals who've shown themselves to be non-adherents and having struggles with adhering, and trying to get them to suppress on oral ART was the initial part of the study, and they needed to suppress for 6 months in the first iteration. Now that's been taken down to 3 months. We've pushed to have that be taken down to a shorter length of time successfully. But basically, it's basically a minimum of 12 weeks to suppress your viral load. Then you can be randomized to step 2. Then you can be on either oral standard of care for 52 weeks, or you got randomized to the long-acting Cabotegravir for 52 weeks. And at the end of 52 weeks, you are eligible to transition to step 3, which is all long-acting Cabotegravir. For the incentive, the total amount of incentive that was provided during the oral phase, step 1, was up to $1,400. So for the entire study.
And that's when you come to a visit and you have a suppressed viral load.
This is when you get your viral load down by a certain log increment. So it doesn't have to be suppressed. You just need to be getting it down by certain log increments, and which is judged at pre-specified intervals. But yes, we should not remember, as John Bartlett said, pay to play was never unsuccessful in any domain of medicine where it was studied. So this was
the oral could be any oral. There was a time when it was oral Cab or oral Rilpivirine, but that's not the oral. It's any oral, right?
It's any oral. We had to have at least 2 fully active drugs. So we sometimes had to like do weirdo regimens. But we had to have at least two fully active drugs. And it wasn't this kind of oral lead-in with oral Cabotegravir period. It was usually three drug ART, fully active ART.
Okay, thanks. I'm just kind of getting them mixed up with the other study, but this is great. Thank you.
Sure, thank you. Yeah, so the incentive is gone. But what the incentive was doing was getting someone through the period of being asked to do something that they had demonstrated they were not able to do.
Which is take oral therapy.
Just take oral therapy. So if viremic people are eligible to just go straight into injections, that may be something that works much better for their life. And that's enough of an incentive.
Yeah.
Oh, you have to wonder, do you think, I don't know whether Joyce is on, whether or not Ryan White would consider paying for a replication of the trial during that time? Like if we decide that you have to be suppressed in order to move over, whether or not there could be money paid to try to get people to adhere to an oral regimen before they get switched over. That's kind of an interesting question, isn't it? Because it's not that much money when you really think about it, is it?
Yeah, and I think that maybe that would be a cool CFAR study or something, just to kind of look at the impact of cash incentives for viral suppression milestones.
So we are allowed to give incentives with Ryan White money. So we have not done it. It's not something commonly done. Like I even investigated at the health institution, like what's the policy for incentives for clinical outcomes or clinical activities, and there's no policy. So it is something though that we can do. And when we get our funding, we could certainly, create a program and have some money. You can't give cash. You can't give cash. It has to be like some type of a gift card. So that is one of the Ryan White stipulations, is you can't just give cash as an incentive.
Wasn't this a Green Fire study? Did you do it on Green Fire? Is Green Fire considered like okay? I don't know whether people liked it or not, but that might be an interesting other thing to kind of replicate.
Who are you asking? I'm not familiar with.
Yeah.
I don't know. It was around that time that I was part of ACTG for a while, and they were like trying to switch everybody over to this instead of like Visa gift cards, this Green Fire card that you could use like a debit card. But we didn't really know whether people would be able to use it or not. I don't know whether they would consider that, Joyce, if she did use. Ethel, did you use Green Fire?
I'm not familiar with that term. We use some sort of like little card But I don't remember what it was called.
Yeah, Green Fire is just the university's way to give out gift cards in a central way. And actually there's a cost per green card. So in addition to the money that's on the card, you have to pay a few extra dollars for each one. So some studies don't have the money to do that, and others are starting to put that in their budget so they can afford them.
And Pat Fisher is saying, and Pat, hopefully you were on earlier when Ethel was giving you such amazing kudos for your work on this study, but that they did use Green Fire for the incentives in step 1 for this trial. So I think that isn't, yep, that is an amazing idea as we think about certain patients who have so many barriers to oral adherence. And, you know, so that the first half of this, or the first whatever few minutes of this, is really just this like fantastic news that we now have beautiful data to show that this population benefits from this, and that this will hopefully influence treatment recommendations. The second part is going to be a little less enthused, or just more like thinking about how we deploy this and what the known unknowns are, I guess. And so we may circle back to thinking about, you know, with our patients with struggles with adherence, do we want to just like, how do we risk stratify them for failure on this strategy, and how do we best support adherence? Because I could actually also see incentivization for 1-month visits for the injection, not just for the oral part as well, for some of our most patients with the most challenges. But again, just wrap that up with real kudos to Ethel, Pat Fisher, Charlie, all of the ACTG, Sonia, who have worked on this study and done a really incredible job. 15 participants from Hopkins is really a fantastic number to have in the study, and more will be revealed, I think, as the data is presented at it says at upcoming meetings, so hopefully there'll be some at CROI. I don't know, or else at IAS, I would imagine. And Charlie is giving a plenary at CROI, so make sure to tune in for that on long-acting injectables. So what I had thought to talk about today was this paper that came out in CID about a month ago, maybe a month and a half, it's an in-depth analysis of virologic failure after switch to Cabotegravir. So sort of the other side of the coin, like when is it not working? And I thought it might be useful to think about as, you know, we're reaching some level of experience with it in our clinic. I actually just got a chat earlier this week from Christian Kilcrease about a patient what to do with a low-level viremia case. So the paper was published in CID. The authors are here. That's a European group. Analysis of 5 individuals reported from various sites in the Netherlands who experienced virologic failure on long-acting Cabotegravir injectables. Virologic failure was defined at the moment when physicians decided to discontinue Cabotegravir. And then a few other notes about the European context. So European indications are for individuals with current viral suppression, no resistance to or failure on regimens with the NNRTI or INSTI classes, and no active hepatitis B. Bi-monthly dosing only. They did not have approval in Europe of a once-a-month dosing option. Oral lead-in is optional, and the dosing window is plus or minus 7 days. So just the differences here, every 2 months is the only option they have. They, similar to us, do have an optional oral lead-in. In terms of thinking about what's previously known, in the clinical trial, registrational trials of this drug, the rate of virologic failure was approximately 1.2%, and that was defined in the trials as 2 consecutive viral loads greater than 200 copies per mil. So with that as a background, next we'll just go to, oh yeah, and sorry, one last point about the data here. So this is from the DHHS and recommendations on the use of Cabotegravir, and from the clinical trial registrational data on Cabotegravir failures. So it's been rare. Investigators have attempted to assess for baseline factors associated with treatment failure in a multivariate analysis of the adult IM Cabotegravir phase 3 trials, presence of at least 2 baseline factors, which included rilpivirine resistance associated mutations on a proviral genotype, HIV subtype A, A6, A1, body mass index greater than 30, was associated with an increased risk of virologic failure at 48 weeks. And so the recommendation is to consider, just to have that in your mind as you counsel people about the utility or efficacy of this treatment option. And then just to keep in mind that for a BMI greater than 30 in the DHHS recommendations, they recommend using 2-inch needles, which are not included in the packaging. The provided needle is a 23 gauge 1.5-inch intramuscular needle. So with that, let's go a little bit into the 5 cases that they're going to discuss. So sorry for the poor quality of this, but it's one transgender woman, 3 cisgender men, and 1 cisgender woman, all between the ages of 38 and 56. The HIV subtype is B and D recombinant in 1 and B in all of the others. The baseline genotyping only includes a 179D. I will come back to that in a minute. Nadir CD4 count was less than 100 for 3 of the participants, or 3 of the individuals, and 2 were greater than 200. And pre-ART viral load was in the 4 to 6 log range. The start of ART varied a bit, but the shortest duration of ART prior to interruption was 3 years. So no one had just started on ART before they switched. And concomitant medications were fairly limited, including 1 with only bupropion, 1 with Ativan, folic acid, naproxen, metronidazole, and then 1 with a couple of other paroxetine, quetiapine, triptorelin, and estradiol, but none with known drug-drug interactions. In terms of BMI, 2 of the participants had BMIs over 30, 1 at 45.5, which was stable during the study, or not during the study, stable during the course of the treatment, and 1 with a baseline BMI of 31.5 that stayed in the 32 to 33 range during the trial. There is 1 individual, the first case A, who went from 29 to 33.5 during the course of treatment. So transitioned across that BMI risk cutoff and did not have adjustment needle size. All of them except for 1 did have the oral lead-in. 1 of them was on, 2 of them were on 2 drug therapy at the time of switch. So 1 was on dolutegravir, darunavir, Cobi. The other was on dolutegravir 3TC at the time of switch. And all of the failures were within 13 months and 1 within 3 months. So there was that one other slight signal in some of these analyses that there might have been a slightly higher rate of failure on the every 2-month injection in the first calendar year. And if you were concerned about it, you might consider doing every month injections for the first year and then switching to every 2 month. So here's some more details about the cases. And the 179, the only one that had baseline resistance associated mutations is this 179D, which I'll come to in a moment, or actually I'll just do it right now. So 179D, do we need to worry about it or not? So here are the main sources of information about resistance mutations. So if you look at IAS USA, V179D is listed as a polymorphism with an impact on etravirine. It is not listed as one with an impact on rilpivirine. In the Stanford resistance database, it's not included in that nice chart at the top. If you look to the side and go through the whole listing, there is a paragraph on it. It is a polymorphic accessory mutation that's found in 1% of individuals at baseline in the absence of any ART exposure. And alone, it's suggested to have about a 2-fold loss of susceptibility to everything except for doravirine, but it's not been demonstrated to compromise first-line efavirenz-based regimens. So overall, it's not thought to have a major impact on rilpivirine susceptibility. And if you look on the package insert for rilpivirine, which has a quite extensive list of potential substitutions that may matter, V179L is listed, but not V179D. So overall, it was present, but it is present in patients at baseline with no ART exposure, so it doesn't imply that there was prior NNRTI-based failure, and it's not considered to be a major resistance mutation, and efavirenz with the same fold change as rilpivirine was still considered effective as a first-line regimen. So that's the only one that was present at baseline. All of the individuals had emergent resistance at failure. So these resistance-associated mutations that are shown here are the ones that were detected at failure. Notably, case B did not have any INSTI-RAMs, but all of the other ones did, although case D had, the 155 pathway, which is low-level resistance to bictegravir and dolutegravir. and higher level to Elvitegravir and Raltegravir, and multiple NNRTI mutations in all of them. So over here, we're looking at trough levels, and don't worry, I'm going to go through these cases individually so we can actually think about it. I'm just giving like sort of an overview of what was shown, but the really remarkable thing here is that every patient who had failure had at least one level that was below the Q1 level for the drug. And Q1 meaning in population, and Ethel, I'm going to murder this, but if you look in the overall population at where people should be below the first quartile, which is the cutoff for being in the range of therapeutic, is the way I'm sort of dumbly interpreting it. But maybe, I don't know if Ethel, you want to clean up what Q1 actually is or not.
You're spot on, I mean.
Okay, so you're below where you should be. So all patients had that for at least one of the drugs at some point during the course of their treatment. The asterisks here indicate when they're sort of longer than they should be after the administration of the medication, but we'll sort of walk through that as we talk about the individual cases. So, okay, so here's the overall details. All failed with extensive NNRTI and INSTI-RAMs, except for one didn't have INSTI-RAMs. All had evidence of drug levels below Q1 at some point in the treatment course. 3 of the 5 had no baseline risk factors for cabotegravir failure. And the other 2, the only risk factor they had was increased BMI, and one of whom did use a longer needle for all injections, so theoretically should have neutralized that risk factor, but none of them had the 2 risk factors that have been sort of put forward as what we should consider for individuals at risk of lack of efficacy. So then I'll go through some of the individual cases. So this is case D. So what you can see here is the hatched lines show the oral lead-in. Each little faint line is a 1-month interval. The circles are injections of cabotegravir. The triangles pointing downwards are suppressed viral loads. The triangles pointing upwards are viral loads greater than 50. And the filled stars are documented low drug levels, so of either cabotegravir or both. So this was a 56-year-old cisgender man who'd been on ART since 2004, so long-term suppression on dolutegravir plus darunavir-cobi for polyneuropathy, which they had opted for a nuke-sparing regimen. He was switched in the summer of 2022, and at 4-month follow-up had a viral load of 260. So this in the trial would have been considered virologic failure if it had been repeated and was again greater than 200. That is the one indicated here. Injections were continued, and the next viral load was drawn at the time of the visit for the follow-up injection. And at that time, which was again on time, the viral load was 610,000, and there were multiple resistance-associated mutations. So he had no baseline risk factors for cabotegravir failure, no missed injections. He did do the oral lead-in. His only con med was bupropion. He had long-term suppression. His BMI was 27, but he did have consistently low drug levels across both of the time points that were looked at. And so, what do I mean by that? So if we look at case D here, he was below in both drugs at both time points, and unclear why. No pharmacokinetic or pharmacologic reason was identified for why that was the case for him. So he's like, I think I did his case first because I was like, this is like the worst possible, like one for feeling confident about this therapeutic regimen because he has no risk factors and he's been suppressed for a very long time and he was on dual therapy previously. And why did this happen? Okay, so next, and I should just say, we are currently talking about 5 cases of failure. Keep in mind that this is like on the order of 1 in 100 that this occurs. So the next case is case C, as this is a cisgender man suppressed since 2014 on dolutegravir 3TC at switch, so again on dual therapy. Only baseline risk factor was a BMI of 32. One thing that's noted in the case description is that he had abdominal fat distribution, so they did not increase the needle length because they're not injecting into the abdomen, and so determined that this was not a relevant risk factor for failure in him. Interesting and seems totally rational. Received 5 injections, all within the recommended time frame. He did do the oral lead-in. And if you look here, so the downward triangles are the suppressed viral load. So the oral lead-in, the time 0 injection, 1 month injection, and then every 2 months received his injections. And then not clear exactly why he had a viral load done at this 1 month time point, because he wasn't due yet for an injection, but his viral load was 9,400 copies at that time. So his CAB levels, so he was checked for whether or not his drug levels were adequate at 10 weeks. So after they'd already determined virologic failure and sort of stopped this, they then checked his CAB levels, which is indicated here by the star. So that was about 2 weeks outside of his window. It was at 10 weeks instead of 8 weeks. But that was a low CAB level and adequate rilpivirine level at this time point here. His only risk factor was the BMI, although again, this was assessed and noted by the clinicians and determined that he would not use the long needles because his fat was in his belly. And other than that, had on-time injections and no other baseline risk factors. Case E, so this is a cisgender woman on FTAF from 2019, a BMI of 45.5. At the time of switch, chronic prosthetic joint infection on metronidazole, which is interesting. I'm not sure what that is with. She did do the oral lead-in and started on cabotegravir with long needles due to her BMI. Her 3rd injection was delayed. And so you can see this down here. So here's the oral lead-in with the hatched, and then the suppressed viral load at the start, the injection at 0 at 1, and then the 3-month injection is here delayed to 11 weeks, where it should have been at 8 weeks after the initial injection. And this was because of international travel, and she did not do oral bridging. However, after this delay, like she has another injection and then gets a viral load done at some point at the appropriate interval, gets a viral load done at some point, and this was 45 copies here. So fully suppressed and has normal drug levels for cabotegravir. Oh, sorry, did have a low drug level there at that time, but had 45 copies, and then just continues on injections at the appropriate intervals until she's checked again here before her injection at this sort of 6th or 7th time point. And at this point, she had 620 copies and had resistance-associated mutations in both INSTIs and RAMs and NRTIs. So low-level failure did have this delayed time point, delayed injection time point, but early on and subsequent to that had what looked like continued virologic suppression, and then did have this slightly low viral load, slightly low level of cabotegravir, rilpivirine rather, but again, at the subsequent time points was sufficient. So, and had adequate CAB levels at that time. So it was only one drug that was low at this time point here. And at that time point, did have a viral load of 45 copies and then got on-time injections. And then at the time of failure, actually had normal drug levels for both of the drugs. Okay. This is case B. So 49-year-old diagnosed in 2013 while in the context of treatment for DLBCL. Baseline 179D, which we've already discussed, is present at baseline in some individuals. Viral suppression on an INSTI ART after 6 months, and then subsequently in I think 2022 was transitioned to cabotegravir and had virologic failure at 3 months with extensive NNRTI RAMs. He was noted to have low CAB levels, so he did not do the oral lead-in. Injection was on time, and this was basically so did the loading, the first injection, then the 1 month, and then at the 3-month visit was already had virologic failure. It does suggest that there was some problem with the CAB injection the first time, and keeping in mind that the drugs are actually injected separately, and as Ethel's study has shown us, not necessarily clear exactly where they're going all the time. But there was no reported abnormality with the injection itself that was noted by either the healthcare provider who administered it or by the patient. So again, sort of a secret event. And if he had not been checked at this time, I don't think anyone would have had any reason to suspect that he was going to have failure. And then the last case I'll just mention briefly. So this is a 38-year-old transgender woman. And here, viral load suppressed during the early period, did the oral lead-in, had on-time injections throughout. And then here has documented virologic failure early prior to the time point for the next injection, did have a low drug level at that point. And the only risk factor identified here was that her BMI went from 27 to 33 during the course of the treatment. And this may or may not have contributed to lower drug levels. And should we be monitoring BMI and making sure we switch needles, or was this had nothing to do with the price of eggs, and or would have not prevented this outcome for this patient? So again, those are each of the 5 cases that were discussed here in this paper. And I think I'll just sort of circle back to, I had put, hopefully we can have a good discussion. And I'd put a couple of questions that I had, but I'd love to open it up to people's thoughts and fears. Like, so in the current approaches, like, what is practice about the frequency of viral loads? And, again, this is a 1% type of phenomenon, but I think we're all very accustomed to telling people that if you're adherent, you will not have virologic failure, because that is generally true for oral ART. And so you can check viral loads once a year. I am not sure that that's necessarily the case, although the number needed to treat in terms of how many viral loads we would have to do to capture a failure on this regimen, I'm not sure justifies it. But just thinking about what should we be doing? What is the role, if there is one, for drug level monitoring? And if we look at these patients with the failures, like, there's a hint at some time point that there's a low drug level, but it's not necessarily coinciding with the onset of failure, and it's not necessarily consistent. So I don't think we could actually say, oh, if we check you at 3 months and your drug levels are fine, then we never have to monitor them again. So then what is the role? Is it if you have low level viremia, you should check a drug level, or never check a drug level, or only research basis until we figure out why certain people have differences in drug levels? The next question is, what is our threshold for concern of viral load? For example, the patient that Kristen Kilcrease had texted me about earlier this week is, I think, at a viral load of like 146 copies. And I think I've seen on the artist formerly known as Twitter, a pharmacist was told people recently how many people had seen viral loads go in these sort of 50 to 200 range, and then resuppressed while continuing on CAB, Rilpivirine. And then I think this leads to a really important research question, which is whether or not there's a difference in low-level viremia on these injectable regimens as compared to low-level viremia on oral ART. Low-level viremia on oral ART has been studied by many people, including John Meller's group, the Silicanos, Francesco Simonetti, many others have looked to Mary Kearney to see whether there is evolution on fully suppressive ART, and shown not. The question is, there's something different going on with these drugs, and it may have to do with distribution into tissues. It does raise interesting questions about whether the viremia you observe might be from different sources, like, is this from lymph nodes or gut reservoirs or other things that are maybe not the first line to cause a rebound in other patients, or to be the source of low-level viremia. And then the other question is whether we've accrued enough patients where we could sit down and look through all of our patients, see what the viral loads are, see the frequency of monitoring, see the number of patients who have detectable viral loads, and if there's any relationship to baseline risk factors or to frequency of on-time injections. So those were the questions that I had outlined. And then Chris Hoffman is asking drug levels for patients in that clinic with undetectable viral load on Cabotegravir. And exactly, like, Chris, this is an excellent question. I'm not sure that we could say, if you have lower drug levels, that it means that you will fail, because we don't have a denominator for these observations. So what I was going to do is stop sharing to try to, maybe some of the black boxes will turn into people. But I just thought, on the one hand, we just got this incredibly hopeful data about this drug, right? and this combination of drugs, and in a population that desperately needs to have options other than take a pill every day. On the other hand, even in our best behaved patients, like those who are always present for injections on time, there is this small but present risk of failure. And like in the context of no viral suppression, it's a no-brainer, but like as we get into the slightly more subtle iterations of either no viral suppression or continue on oral ART, how do we decision make, and how do we get to the precision medicine approach of knowing who's going to have virologic failure on these regimens? I guess I'm assuming that it's a host factor and not a viral factor, but I'll just stop talking and hope that someone else will start.
Hi. No, excellent discussion and presentation. Thank you so much, Eileen. This is super helpful information. I mean, I think it's sort of clear that we have some things to hang our hats on, like from the clinical trials and like these kinds of studies. And it definitely is sounding like the way that we think about how frequently we're checking viral loads on people on oral versus injectable has to be different. This is demonstrated, like in people who clearly have adherence, we can't be as confident about you know, what's happening with the viral load, and just because of the pharmacokinetics, right, of a long-acting injectable versus a daily oral medication, that risk for resistance clearly occurs. So, you know, I think that in terms of sort of practice, and you know, I think I would be interested to hear if others have heard about like what is the guidance for frequency of viral load. I know that the Ward 86 has some, you know, in their protocol, they have some guidance about when to check the viral load. So I think it's like the people who are every 2 months, it's like with every injection, they're getting a viral load checked. And then the people who are monthly, it would be like every 3 months or something like that from my recollection. So my thoughts are just in terms of the practice. I think in my mind, it's sounding like, and again, to your point and to all the points, this is like a very small number of cases, just in terms of like the percent of people who are failing despite adherence. But to be conservative, I would suggest like an every 2 month viral load. Sounds like what would need to be happening. And then our comfort with sort of low level viremia is much less comfortable than the people who are on oral ART. And like if somebody has a detectable viral load, you know, a more frequent check again. I also think just talking with Heba about whether or not we can get resistance testing on people who have a lower level viral load, and these people on injectable would be important because, you know, there have been times that I've ordered genotype on someone who has some low level viremia and it was really quite low and it would result. Now they're just like not doing it. So I think sort of, you know, out of an abundance of caution, I would suggest, again, viral load every 2 months. If there's a detectable viral load, check again within the next 4 weeks. If it remains detectable, and maybe even, you know, when you have it detectable, what's, you know, and talking to Heba about what's the threshold for when we can get a genotype on those people. And then definitely more like research about, you know, looking at therapeutic drug levels. And I think that's something else we could add in terms of, you know, these people who do have a detectable viral load, you know, just the process for that, making sure we know how to access it and that it's covered. And then these are like really clear areas for research. And then just the last thing I'll say is I really lean towards the monthly injection. That's really my bias, because the rates of failure were higher in the people with every 2-month injection.
In that first year in particular.
For the first year,
Yeah.
Yeah.
And I wonder about that. I do, because like all of these cases based on the European standards are every 2 months. So is this really just observing what was already sort of suggested in the trials, which is that maybe for the first year, every 1 month is superior? I think all of those things are really great points. And I wonder about whether we could build out some sort of CFAR Ryan White investigation where people are supported to be on these regimens, where we collect samples that can be used retrospectively to look at drug levels and to do resistance testing on a research basis, if not in a clinical basis, and incentivization to be at the visits, which might like relax some of us about, like, I feel nervous about putting some people with major problems with appointment adherence on injectable medications, because if they're occasionally lost to follow-up like that, but maybe with the added incentive of a financial incentive to be present, that would really help. I think Joe Co is saying in the chat that 1% is low, but not the low that we're used to. Totally agree. Like, used to be able to, well, you could say, like, if you take your medication every day, you don't have to think about this. And then Liz Gillums is wondering about pharmacogenomics. And I think this is another, like, if we thought about like how many patients we have, if we sort of stood up a routine clinical care with an add-on observational biospecimen collection study, could we try to get closer to precision medicine? I think that's a fantastic idea. Ethel?
Yeah, I was just gonna say, so all the points that have been raised by others, I think are really important. What makes me worried with this case series is that, particularly the rilpivirine levels that we're seeing were kind of in the range of 1 to 3 times the IC90. And that kind of variability in the rilpivirine levels is a big concern, but also seen in the prevention trials in HPTN 083, the people who did seroconvert had some period, the kind of month or 3 months before their point of seroconversion, where they had a dip in their levels after an injection. And that's extremely unusual to see a dip after an injection. You usually see a hump. And so one of the things we've wondered about is there ever inadvertent intravenous administration? If there's inadvertent intravenous administration, then you don't form a tissue depot and you do not have long-acting release. And whether this could be one of the things responsible for the really marked inter-individual variability, particularly for rilpivirine. I've talked to an allergist about this. There's apparently something in the adjuvant that can provoke a highly inflammatory hypersensitivity reaction. And we see that, it's listed under the prescribing information. It's been well documented that sometimes there's this hypersensitivity reaction. You hyperventilate, your heart rate goes way up, you're sweaty, and then it kind of dissipates over an hour. But some people don't have that, and it's felt to be IgE or IgG mediated. There's some people with a sensitivity to this adjuvant, to the component of this adjuvant, that mount that response, and some people that do not. So could you have a clinically silent inadvertent intravenous administration is one of the things I would worry about. In terms of the practical, pragmatic aspect of checking levels, one of the things we could consider is we have developed a finger stick assay for testing cabotegravir and rilpivirine levels. It is validated. We validated it in the CPAL, and it has shelf life stability up to 7 days. So maybe we should do another pilot, CFAR pilot, where anyone who has any detectable viral load who's on these long actings just comes and gets a finger stick, and we look at whether they're in a dangerous level. And I think there'd be a role for considering a reload at that point. So if you've documented a subtherapeutic or under 4 times the IC90 concentration in someone with a viral load that's peaking its head above the waters, then perhaps reloading is a consideration, is a rational approach. So maybe we'll look into piloting that. It doesn't cost anything. We have the assay, we created it, and it might be a nice adjunct to clinical care.
No, that sounds amazing. I see that Kristen Kilcrease is on, and I don't know when you joined, but Kristen, I'd love your thoughts as the person for whom most of the patients have been funneled in terms of what you think would be most useful, and whether in your review of these patients, you've seen a lot of low-level viremia or not more than you would expect from oral agents. And sorry to ambush you.
Hey, that's okay. So no, I wouldn't say that I've seen a ton of patients with the low-level viremia. If anything, I've actually seen more patients when we switch them over to Biktarvy with low-level viremia. The patient that I sent you earlier this week is kind of similar to Sarah's patient from BCHD. Her viral load, however, wasn't 300s, it was like 178, and has continued to decline. And so similar thing, nothing on archive GT before or after. And so it kind of made me wonder if we should, if maybe the extenuating factor here is, injection technique. It is 2 injections, as we mentioned earlier. And so, maybe this time around, it just, kind of got injected into the wrong area, slightly into the wrong area. Maybe the patient massaged the area to kind of mess with the absorption rate of the medication. And so I know that in our protocol for patients that are on monthly, we are getting viral loads once every 3 months, and we're getting them once every 4 months for the Q2 monthly. Now, that doesn't mean the patients always do what we ask them, but it is built into our protocol. The nurses and pharmacists are doing fantastic jobs of reminding patients to go get those viral loads to make sure. And so I don't know if I have an answer for what we could be doing differently. I did like kind of the idea that Ethel was stating about, if we could potentially do a reload, but, obviously we would, have to do drug levels. And I don't know kind of what the ability for us to do drug levels would be. I think, probably a research use only type situation, and then, retrospectively look back and see what we could find. But it's just kind of hard to say.
Yeah, no, those are great points. And I think, so I had a patient this week who has struggled with oral ART for years and years. She is very interested in injectable therapy, but she actually can't get to Bartlett. She works somewhere. And so I was considering looking into having a local pharmacy administer it if that's possible. But this gives me some pause, right? Like, if there's so much variation based on injection technique, and, at least at our site, we have people who are experienced who do this all the time. I don't know whether that should be factored in or not. And, presumably it can't be, like, if it's that operator dependent, that's going to be a problem if it's, but it's just something to think about. And then go ahead.
I don't want to think it's, so operator dependent, because it is a rather large area that we have to operate with injecting the medication. So, I just think, there's some factors that we might just have to consider of, maybe this one time it kind of missed it by just a little bit, or maybe the patient, massaged the area or something, because we have had patients that have been reporting some nodules and extensive soreness. And so it could have been that this time around.
Yeah, no, that's a great point. And then I see Sarah Sarah Rivas is posting that her patient, who was at such a fantastic discussion when Monica Gandhi was here, whose apex viral load was 300, stayed the course, and most recent was 55. And she had an archive genotype done at the time of the viral load of 300 with no new mutations. I do wonder, and I actually don't know, I should have looked more closely in the paper, whether they were doing archives, again, which would be proviral genotypes, versus looking at the actual virus that was in the plasma at the time of the sample to look for the resistance-associated mutations. Because I think that those potentially may be different. But you know, Sarah, your case is like a perfect example of where like baby in bathwater here, like should one viral load of 300 stop a therapy that's saving someone's life? I think the answer is probably no, but you know, again, so challenging. And did that patient start lenacapavir or did she just stay on cabotegravir?
No, Kristen and I talked about it and we're like, would this actually get approved? And we said, let's just hold the course and see
Yep.
how it goes.
Yep.
Yeah. And I think a lot about the genotype information we're using and the context in which we had that in the past. And if it's really reflecting what's reality, these questions keep coming up.
I was just gonna say, I also feel like there's clinical factors that can raise viral load apart from untreated HIV, like getting a flu vaccine and having kind of a moment of immune distraction. And so though it makes me nervous, and though I've seen this in the ACTG 5359 study to have detectable viremia in people, you know, on the long actings, per protocol, we go ahead and often it settles down.
What's the protocol cutoff?
I think it's 200.
Okay, but you have to repeat before you do
Yeah, so
anything,
it's
right?
kind of
Yeah.
like within that window between 20 and 200 where you're like, and you're like
Yeah.
chewing fingernails, but still injecting. That has been our practice. I also wanted to say, I feel like a drug that's going to be, you know, sabotaged or inactivated by massaging the injection site is not going to be a good drug. And I feel like I think that when we did MRI imaging of these depot injection sites for long-acting CAB, just in a healthy volunteers study, you see a ton of inflammation around the depot, and that's good. That's how you uptake drug. Macrophages that go to the site and uptake drug is how you absorb it. And I think I feel like it would be unlikely for just massaging the site to implicate that. We did see patterns of it leaking backwards out of muscle into subcu tissue, sometimes just going in subcu tissue, going in various areas, which affected the PK, but not to the tune of altering the trough, which is
Right.
what is most important for antiviral efficacy.
Right. And Kristen's also mentioning they've only had one true failure in our clinic due to a rilpivirine or resistance-associated mutation. And was that present at baseline?
It was, but what's very interesting, and I've actually come across this on several other patients, and it's actually quite scary. He had a 188HL at baseline, and that was in 2015. But for some reason on that genotype report, rilpivirine is not listed.
Right.
And I don't understand that because it was approved in 2011.
Right.
And so I've come across that on at least 3 or 4 other patients. And so it, warrants caution to, just kind of double check genotypes. I've seen from anywhere between 2014 up until 2017, where for some reason rilpivirine's not listed on those genotypes.
Yeah, thank you so much. I'll just be mindful that it's after 1, but thanks everyone for coming. Have a wonderful weekend, and more to follow as we roll out these long-acting agents.
Thank you. Great session.